It's a great pleasure to welcome and introduce our next speaker, Dr. Nazir Lone. Naz is a consultant in critical care working up at the Royal Infirmary of Edinburgh and also a researcher at the University of Edinburgh. And Naz works and researches in the area which has been created by medicine's advances in prolonging and sustaining life. And he's going to share some of his thoughts and learning around the challenges and dilemmas for professionals and for public which those advances have created.
Thanks very much, Mark, and thanks to the SPPC for inviting me to speak today. As Mark says, I currently work as a doctor in intensive care in the Royal Infirmary of Edinburgh, so just down the road from here. And my research interests are focused predominantly around critical care as well. I did spend 10 years as well training as a respiratory registrar with a big focus on lung cancer and a real focus in palliative care there as well. But obviously now my job is almost exclusively critical care. So I'm going to start just by a little bit of framing of what I'm going to come and continue talking about. So I'll let you watch this first. Oops. So a matter of life or death every day in the intensive care unit. I think if you look past the dramatic license there and the music, I think the message which comes through loud and clear is what we do is we save lives in often terrible circumstances. That's our job. And in fact, we're getting better at saving lives as well. These are published a few months ago, our national audit report. We publish every year in Scotland. Mortality is the lowest it's been now for the last 10 years for patients coming to intensive care units. So over 80% of people coming through our doors, they get to live and they go home at the end of their hospital stay. And I think you could well ask, what on earth am I doing speaking at a palliative care conference then? And I think what I'd like to focus on really is flipping that 80% and focusing on the fact that almost 1 in 5 of our patients actually are dying in quite often traumatic circumstances. And despite the fact 95% of our training is around trying to keep people alive and do lots of aggressive intensive therapies, actually probably about 50% of my job as a consultant is about communicating and managing death and dying in the intensive care unit. So put in a slightly wider context, looking at deaths within Scotland, overall, we know around half of deaths in Scotland occur within hospital or hospices. These are data freely available and not as robust as the ones I would normally use in my research, but trying to get this information is actually quite challenging. And I worked out probably around 12% of Scottish deaths occur within a critical care unit. So that includes intensive care and high dependency care. They're areas of which, both of which we work in as one specialty, really. But we have to remember that, quite similar to hospice inpatient beds, critical care beds are actually very limited. They're very expensive beds to run for hospitals, acute hospitals. So we are really quite limited to the number of beds we have in Scotland. So if we think about the amount of death and dying going on and the unit of measurement being per bed per year, actually we find that critical care has even more death and dying per bed than hospices do. So I think, without doubt, as it definitely feels, particularly when you become a more senior doctor working in critical care, it seems to be actually our bread and butter is death and dying, and the issues that arise around that. Now, from the clip you saw there, that looks like what we're seeing as young people in major road traffic accidents, people with end-stage disease getting another lease of life with a transplant and helping them through the post-transplant, post-operative period. And that is true. We do have those people still coming through our doors. And if you watch that entire series based in Melbourne, it would appear that that's what most patients look like in intensive care. And that is absolutely not the case. This is, again, from our audit this year. The majority of patients coming through the doors now of intensive care are over 70. They have chronic health problems. And the reason they've come to intensive care, yes, it's sudden. It's definitely unexpected to them and their families. But there is much more an issue around managing chronic diseases and when things get worse in a chronic disease pathway. So what that now leads to much more for us is when we are referred somebody who needs to come to intensive care for life-saving treatments, The question that arises is it actually the right thing to do to bring them to intensive care? What we're trained to do is give people an anaesthetic safely, put them on life support machines, manage those machines and the patient through that process. And that, in fact, I would probably say as a senior doctor now, that's actually probably the easiest thing to do. That would be the easiest pathway to take. That's what families are expecting as well. And actually, what stops us all is whether or not that's the right thing to do, because there are downsides of coming through intensive care. And taking the time in that short window when someone's critically ill, we're being asked to consider admission to intensive care. We then have to try and pause and gather enough information and have those quite challenging conversations with patients, if they're conscious, often they're not, and usually family members and relatives, about what the right thing to do is, trying to understand that person's viewpoint. And that takes a lot of time, and that's not time we often have at our fingertips. So just to exemplify, this is someone a few months ago who came through our unit who I met. Kenneth, an 84-year-old lawyer, very mentally sharp and active still, and just had chronic diseases of hypertension, diabetes, and really managing quite well at home still independently. Had been slowing up for the last year, but it wasn't hugely affecting his life. And he that morning had suffered excruciating abdominal pain, the worst he'd ever had in his life. Very frightened, dialed 999 and came straight to the emergency department. And on arrival, he was already critically ill, needed immediate resuscitation, and sent to the CT scanner to get some more information about what was going on. And that scan shows free air in the abdomen. So we knew that an organ had perforated, most likely his bowel. But unfortunately, he was already developing multi-organ failure, really quite rapidly due to septic shock. It's a very common scenario we deal with every day. And the benefits, particularly now in the current NHS and even acute services, particularly in critical care, this is very much consultant-led and consultant-delivered care. So the people involved in trying to figure out what the right thing to do is, in this situation, whether it was the consultant A&E doctor, a consultant surgeon, a consultant anaesthetist who'd have to get the patient through the operation, and me as the person trying to piece together the bits after the operation too. And we all agreed that the only option here really would be, if we were going to go for life-saving, would be to go through an operation, but with huge risks and actually a pretty unlikely chance of coming out of this successfully by our definitions of what success is. And the alternative here, there really was only one other alternative, and that was immediate palliation. He was already in the dying process with this catastrophic illness. So amazingly, he still had full capacity and was fully conscious. That doesn't happen very often. As people become critically ill, they become delirious and comatose. And it was lucky for us because there were no family members that were contactable in this emergency situation. And we really had to decide within the next 10 or 15 minutes what we were going to do if there was any hope of getting him through this. And that was a conversation I had. It usually is the critical care doctors who have those conversations with an appreciation of what this means after an operation, and had a relatively nuanced conversation. Kenneth was wanting details about aspects of this as well, what this would mean at various points. And what we came back to, and what he wanted to come back to, would be what would happen if he opted for comfort care. And it was very clear what would happen. We would make him comfortable, but he would die, and he would die probably in a matter of minutes or hours. It would be the most likely outcome. And he considered that and opted for aggressive treatment, understanding he may die during the operation, he may die in intensive care afterwards. He would be one thing we could predict would he'd have a prolonged period of life support therapy afterwards. If he survived intensive care, he'd likely have a prolonged period in the hospital and may never get home. And if he did leave a hospital, it might end up being dependent. And those issues that had to be relayed in a very short period of time, and he had to make that decision, or we came to that decision in the space of 15 minutes. And he did get his operation, and I'll follow on later on about what happened there to Kenneth. So what's absolutely crucial in these decisions is, first of all, as a researcher in particular interested in outcomes, is understanding what the likelihood of successes of the treatments we're giving. And I think these components around trying to understand what the right thing to do is at this sort of sharp end of the wedge is having at our fingertips data around treatment success, but also fully appreciating the burdens of treatment. And those burdens I'm going to talk about shortly. But clearly, as happens, as I'm sure many of you who work in palliative care, there is a huge amount of uncertainty around all of this. But the second component here, it's great if you have all this information at your fingertips, but not only in communication do you need to relay that information in terms that are understandable to a patient, but actually, more importantly than that, is understanding where the patient sits in this and what they value in terms of success, what their definition of success is, and what their definition of burdensome is. And guiding that process through to arrive at a decision. So as palliative care people, I think communication is right up there as competencies of what are needed. And I think if you imagine trying to compress those skills down and arriving at decisions which are genuinely life and death decisions within 20 minutes, 30 minutes, very challenging situation to do this in, but that's actually what we have to do every day. So moving on to some of the outcomes and what success might look like in an intensive care unit. I've got 3 specific scenarios which come about very regularly on a daily basis. Some of this is work which we've been doing in Edinburgh, just trying to put some figures and numbers on things to help facilitate those conversations. So age, big issue, and what's absolutely clear, and internationally throughout the world looking at data, the older you are, regardless of other health problems, the less likely you are to do well through intensive care. And these are figures particularly useful I keep at my fingertips when I'm having conversations. The bottom line of that Kaplan-Meier survival plot is those aged 80 and older. A year out from intensive care, again, we're not really talking about hospital outcomes. That often isn't the most important thing to patients. A year down the line, 30% will still be alive. And at 5 years in that oldest group, around 10% will still be alive. So those are useful figures to have at your fingertips. If a patient wants that sort of information and detail, sometimes they don't, but sometimes, at least in your own head as a clinician, you know ballpark what we're talking about here. As a population average, obviously, and everyone's an individual, gives you a ballpark though. This is work we've just finished this year. Another group of patients, very challenging, very common in Scotland, patients with alcoholic liver disease. And they happen to become critical quite often because of poor reserve. This again was really needed by us. We're a liver centre in Edinburgh. We take for the whole of Scotland for people with severe liver failure. Understanding that, in fact, these are pretty terrible outcomes, and these are people in their 30s, 40s and 50s coming through the door, of about 80% mortality at 5 years, and the darker shades here are the closer to the ICU admission, to those in black dying in the ICU. And around 20% are alive at 5 years down the line. And I think this work in particular, I think my take-home message for this and what I apply to my practice is it's very challenging to decide at the door whether to bring people, and often with alcoholic liver disease people have lack of capacity for other reasons such as encephalopathy. But if they pull through their ICU stay, we have usually a quite prolonged window in the hospital to actually start these conversations about what will happen next time, because there will be a next time with alcoholic liver disease as a chronic disease. There's quite a lot of work to do within the field of hepatology and liver disease, unlike heart failure and COPD and respiratory diseases where there's already been quite a lot of engagement with the palliative care community. And the other bit of data, this is international data, I think underpins almost every single DNA CPR conversation we have. Again, people may not want the details, but it's very useful to know if you have a cardiac arrest in hospital, you have a 90% chance of ending up either dead or with moderate or severe brain damage. And I think those are useful figures to have at hand. It's not like what you see in the movies. And the older you are, the less likely you are to do well. So I think those are just fundamental data to underpin those conversations, and whether or not somebody wants those specific data, up to a patient and an individual interaction, but useful to have still. So the static issues of single diseases, single outcomes, all well and good, but actually as a clinician, when you're seeing somebody, you're always trying to piece together what's been going on in the last few months, or years even for somebody. Where are they on their disease trajectory? And this is very commonly presented in palliative care literature. Professor Scott Murray, who's a colleague in Edinburgh, who's here today as well, published this over 10 years ago, looking at trajectories at the end of life. And we are trying very hard in critical care to try and tease out what this means for people who become critically ill. Trying to, again, use the Scottish data. We're trying to tease out using imperfect methods, but seeing that already very clearly using simple things like age and comorbidities. You can see very clear different trajectories, the 5 years before intensive care and the 5 years after intensive care. With those with comorbidity, almost whether old or young, are having very high levels of hospital contact, acute emergency healthcare contact, and afterwards, really quite high levels of mortality and morbidity being measured by very, very frequent contact with the health service, some of which is directly as a result of coming through intensive care. So just trying to get even more nuanced with some of the data around outcomes to help those difficult decisions at the front door. So great, we're getting better, we're getting more data, we're getting better at that information we need. There's always uncertainty, but some of it's becoming clearer. But the flip side of this is, if you come to intensive care, what is that like? Is there a downside to intensive care? And 20 years ago, that wasn't the case. People look peaceful, fast asleep, it looks like, to relatives and to us, to be honest, as well. We thought we weren't doing any harm there. And what's become very clear in the last 15, 20 years of increasing research is there are major downsides to coming through intensive care. And I've just got a short clip here, and it's better heard, I think, from someone who's been through it rather than me describing it. So I'll just play that. Nancy Andrews there was obviously describing recovery after an emergency surgery with a catheter in and ward rounds, something which I would barely bat an eyelid at going around my intensive care unit doing a ward round. So what's very, very clear is there are major, major harms coming through intensive care, and they're not just psychological. She was predominantly describing the effects of delirium there, very common in critical care. And the evidence in this area has exploded really recently, and we're getting much better information. Again, using our data in Scotland at relatively broad outcomes, we found that actually even if you've managed to survive ICU, get home again, you have a 30% increased risk of dying over the next 5 years compared with other hospital patients who don't need intensive care, and your likelihood of coming in and out of hospital is substantially higher than other hospital inpatients. So a burden there ongoing from having survived intensive care. And multiple domains that have been looked at, ICU survivors just do worse than the general population, whether it's quality of life, cognitive impairment, and if you look carefully here at this older age group, they're actually approaching levels of cognitive impairment required to diagnose Alzheimer's disease. That's strongly correlated with the amount of delirium you have as well in intensive care. And more broadly than health outcomes, for those who work before they come to ICU, 50% of them 12 months down the line still can't return to work because of disability. So that immediately starts you being able to process as the clinician, as the person who's doing this to people, what this actually means for them in the longer term, and can very, very well much better inform those conversations. This concept as well of, well, if that's somebody who can't work anymore, what if they were the breadwinner? And then what does that mean for their family as well? And that really, quite recent literature in the last few years has looked at the effects on family and carers. And these papers published in the last few years show very high levels of psychological morbidity in their family members, presumably related to the traumatic time, but that doesn't go. A radical change in relationship and circumstances, many having to take on a carer role, many losing their jobs or unable to continue working because of the carer role they take on as well. So this burden goes well beyond the ICU patient and actually affects even more people in this context. So thinking specifically around the burdens of intensive care, this is information coming from people who've survived, not those who've died. And I think it's reasonable, I certainly do, extrapolate these experiences to those who can't tell us what they're experiencing because they're mechanically ventilated and intubated. And applying that, I think, is a very reasonable approach. You could argue, well, at least that's time limited. They will die at the end of it. It's not going to go on for a protracted period. But the one thing that will go on is the experience of the family members at that time as well. And that potentially has no end to it. So the ramifications of someone dying in ICU for family members can inflict a substantial burden beyond the intensive care period. Something you can imagine now, this is well beyond my areas of expertise of how we go about dealing with that. And again, very recently, it's almost as the intensivists have finally realized that there are things going on with people beyond correcting their physiology. Intensivists have now started looking specifically, collaborating with palliative care colleagues around the world at what happens in these bereaved relatives in particular. And this was just published a few months ago from an ICU in Paris. And France has a relatively similar practice to what we do in the UK, so a little bit more applicable to our sorts of populations. And you can see here, these are 6 months down the line of bereaved relatives. Again, these are using validated survey tools. Around a third have depressive symptomatology. Almost half have post-traumatic stress symptomatology, and a third on a validated scale, a high risk of complicated grief. And this, as I've been reading this literature, really worries me because we have absolutely no connections with bereavement, palliative care, when it comes to people dying in the ICU for ongoing support of relatives. And that's a lot of relatives across Scotland when you start adding up those numbers as well. The intensivists as well, borrowing from the palliative care literature, decided to try an intervention in a randomized controlled trial. That's what we do a lot of in intensive care, lots of randomized controlled trials, and decided to try sending out a condolence letter at an appropriate time point after death to families to see if that improved measurable outcomes. And the primary outcome here was depression anxiety measured by the HAD scale. That showed no difference at the primary outcome measure, which was 3 months. But slightly worryingly, at the other time points, there was actually an increase in depressive and anxiety symptoms in those who received the letter. So before we sort of embark necessarily on applying knowledge from other areas, we maybe have to stop and think about, are we actually going to, fair enough, have no effect, it might be a bit of a waste of money, but no effect, but actually cause harm. Ultimately, I think that makes me stop and pause as well about what do we do, what should we be doing in this area. So, I mean, these are growing problems, and we are having more data. And for some people, the effect on relatives, when you speak to patients, particularly by themselves without their families present, probably what they worry about most if they went through intensive care is the effect it would have on their loved ones, not themselves. So actually, these outcomes become very pertinent for some of our patients who are trying to weigh up what the right thing to do is for them when they're faced with critical illness. So coming back to Kenneth again, what happened to him? He had an operation. It was much more difficult than expected. At laparotomy, he had 4-quadrant contamination with bowel contents. That's usually not a great sign. It means a much higher risk of septic shock, requiring multi-organ support, and higher risk, as you can imagine, although you wash it out, higher risk of subsequent infections in the abdomen as well, which usually prolongs intensive care and reduces chances of recovery. He did slowly improve. It took a long time, was entirely lacked capacity throughout that time as well, and a really quite prolonged period of life support. 10 days is a long time to be on life support, and really ravages the body separate to the disease process. And the family, particularly a daughter, was the main spokesperson for the family. In intensive care, we do have the luxury, I would say, in many ways, of being able to communicate daily where necessary, led by consultants, but as a multidisciplinary team with the ICU nurses as well. So daily contact with that family, conversations between 15 minutes to 1 hour on a daily basis, trying to establish trust, a rapport. The difficult conversations we don't have initially, particularly if there's resistance, and in this situation there's very clear resistance. The daughter felt, he's looking great now, we've done a good job, he needs life support treatment, he decided himself he wanted this, we need to do everything. And the real issue that was arising was, he's at very high risk of complications, and if he redevelops multi-organ failure, I think we can say with some certainty now that there is that we're not in the same grey area. He would not survive a further bout of multi-organ failure. We would genuinely be delaying death in that situation, but very resistant to take on board those issues as a family. But we did manage to extubate him, and delirium settled, and when he was able to partake in conversations in the intensive care cell, very clear, he did not want to go through this again. He asked, again, as an educated person anywhere, he wanted to ensure a DNA CPR form was put in place with clear ceilings, which we respect his wishes. And again, family unhappiness about that, but at least in this situation, again, doesn't happen very often, we were able to reach that point with the patient as well. As true informed consent now, someone who's been through it. So I think this brings me on to the other key aspect of what we do, which is communication. There is an evidence-based building for us specifically in critical care. You can see the trials have been done. I quite like this one. Some colleagues in Australia have actually looked specifically at trying to implement a communication skills training package for intensivists in their hospital, specifically targeted at the discussions which have to happen in compressed timeframes when you've been referred someone and trying to decide whether or not coming to intensive care is the right thing to do. So that they're keen on trying to roll that out more widely in Australia. And Scotland's actually a bit ahead of the curve. Kirsty Boyd is a consultant palliative care doctor in Edinburgh. She co-leads the EC4H, effective communication. Some of those workshops are very relevant to critical care doctors. A number of my colleagues have been on those workshops. And NES, the National Education for Scotland, is developing online tools as well. So I think there is a real awareness we need to get better at communication, and we certainly need to get better in critical care when it's such a key focus of what we do. And we've already heard about realising realistic medicine, but the policy developments on the horizon, I think this is going to make it even more important. The respect form, some of you may be aware of, it's being introduced south of the border to replace the DNA CPR form. It's just one component of discussing intensity of treatment. I am anxious if that is implemented without sufficient training and communication, because my real worry would be come to a bedside at 2 a.m. and have scrawled in capital letters on this, must be for ventilation and multi-organ support, where I have not been involved in that conversation, and the people making those decisions and having those discussions don't really have a concept of what that means for the patient either. So I'm anxious. I think it's a very good idea, but I think there needs to be information from a clinician point of view as well about what that means for a patient. And there are some people with the knowledge involved in the RESPECT programme down south, and I'm keen if we do this north of the border, we have appropriate representation of stakeholders in rolling out that programme in Scotland. I think we've had a number of high-profile cases recently where, I'm sure many of you would have been following the Charlie Gard case. The critical care community was following this case very, very closely, even for adult critical care. It potentially had huge ramifications for us as well. Really tragic story, and I think those of you who followed it, I'm sure will feel the same. But what this really came down to, when you read the course transcripts, I have no idea if there was a communication issue. Obviously, we weren't privy to those clinician-parent conversations. But what you can understand from the transcripts from court very clearly and the rulings was this ultimately in law came down to a matter of burdens of treatment versus benefits, and whose viewpoint from burdens and benefits. And that's the nuts and bolts of what we do. And clearly parents, there was a divergence of opinion about the burdensome nature of intensive care treatments, and what they viewed would be they'd value as benefits. And parents again speaking from the point of view of their child. So very challenging, and clearly the court ruled in favour of the independent advocate for the child as well as the healthcare professionals. There are cases where we do know communication was at fault. This case, the Jana Tracy case, many of you I'm sure are aware of as well, has radically changed practice around discussing DNA CPR decision making across the health service, primary and secondary care. We cannot sign a form without discussing it unless for some very specific narrow circumstances. But if it's anticipatory, it must be discussed. And those discussions need to be handled sensitively and very much patient-centred and focuses what they think is important, not necessarily what we think is important. Again, the media reporting on this, pretty savage in terms of, in relation to the healthcare professionals involved in the hospitals, almost nefarious what they were trying to do, doing stuff behind Jana Tracy's back, signing these forms. And even more relevant to us in critical care is the David James case, which wasn't as high profile a few years ago, but that's had a huge ramifications for us in critical care, because this was about applying ceilings to therapy in terms of multi-organ support, not just resuscitation orders. When somebody had been in ICU for 6 months with a brain injury after an in-hospital cardiac arrest, showing no hope of weaning from ventilation. So subjected to 6 months of intensive care and a divergence of opinion again between the intensivists and the family. And that finally went all the way to the Supreme Court, who ruled in favour of the family ultimately. And I think this very much feeds into our thinking now around these discussions as well. If they go wrong, if you don't have sufficient training or self-reflection about how conversations go, we can end up in these really quite disastrous situations. And you might ask, why am I taking reference from the Mail Online with all of this, rather than necessarily some ethics journals? And the reason is, if you read this piece, it's really quite upsetting as a doctor working in intensive care, I think as a human reading it, as to what the family's view was of what had happened. And these are quotes directly from that piece. Sentenced to death by these ceilings of therapy discussions, legalise murder, a victim of neglect from day one. And I can't recognise that. Remember, in ICU, we have one-to-one nursing, 24 hours a day shift and night shift. I find it very surprising that we got to that point, looking after someone for 6 months, daily ward rounds, consultant involvement every day. And this way of medical staff killing off the old, that was in direct reference to the Liverpool Care Pathway, which the Daily Mail obviously was a big, one of the big reasons why that got scrapped in the end. So that fed into this story too. So the reason why I reference this is because actually it's the most widely read media in the UK. There's 23 million individual readers of the Mail Online every day. So if I'm going to a room having a conversation, I keep that in mind, because actually in a room full of relatives, it's likely one of them at least may well be taking a cue from this. And I come in quite naively thinking everyone thinks we're doing the right thing, we're there to help the patient. And if actually their viewpoint is we are there trying to kill off people to generate beds in critical care, there's lots of stories about critical care being under pressure as well. I think it's worthwhile realising that might actually be occurring to somebody. It really doesn't occur to you as a clinician being relatively naive in critical care. So I think much bigger than getting better with communication, much bigger than getting more data, which obviously is half of my job. I think it's about what exactly the SPPC and charities such as Dying Matters and Good Life, Good Death, Good Grief do. I think the awareness of death as a natural part of the life cycle. I mean, great last two talks as well. I think this feeds directly into this. An awareness that actually pain and suffering is part of being human, and it can happen at the end. We can try and relieve as best we can, but it can happen. And trying to counter what we saw in that first clip of actually, you know, we almost have a magic wand here. We can fend off death forever. Because the societal expectations are becoming more unmanageable. And Mark mentioned at the beginning around the It Takes a Village exhibition. That was great. I went to the 2 years ago to that. I think it was 2 years ago. Really moving, very powerful. I think work like that needs to happen, because what we're doing, however good we get, it's not going to be enough. It has to be a much wider societal conversation. And obviously I'm saying that quite selfishly, because actually then when I come to the patient at 2 in the morning, I'm hoping I can have what happens very rarely at the minute is some acknowledgement and acceptance from someone from their own humanity that the end must come at some point, and these are just other decisions along that way. So I was very pleased to be involved this year putting a critical care angle on there, which hopefully will have some wider reach than the reach I have as a researcher or as a clinician every day. And again, reasons why I think this is really important. We know what's happening. That was from a tweet Mark put on Twitter a couple of days ago. This is happening more and more and more and more. For me in particular in critical care, these are the conversations I'm having to have without clear benefits for critical care and substantial burdens. And the other thing to bear in mind is we do take quite a lot of a societal lead, cultural lead from the US in a lot of things. You know, we're 10 years behind them on the obesity curves for adults and children. And this really sobering research done by Hannah Wunsch, she's an epidemiologist and intensivist in the States, I think in my mind quite horrifying. A normal death in the US is basically being attached to a ventilator. If you come into hospital with a surgical problem, 80% of people dying in hospital after surgery are dying in intensive care. And 50%, this is, if you look at the oldest age group there is 85 plus, it's the same. 50% of people with a medical condition, you know, severe stroke, severe pneumonia, in their 85 plus, they are dying attached to ventilators and life support machines. And I think this societal view, this cultural viewpoint, that is the right thing to do. We've done everything we can, and we've flogged them, and they've died attached to life support, is definitely not a society I want to be working in critical care in particular. And I think that's why the societal approach, the societal engagement is much more important, I think, than anything I might do as a researcher or a clinician or trying to implement improving communication skills. So I'll leave you with one final thought is, what about doctors? What do they choose at the end of life when it comes to treatment intensity? People perhaps who are maybe more informed. And this is a really neat short study done in the US. And doctors, compared with the general population, choose not to die in hospital. They choose to die in hospices or at home. In the last 6 months of life, they choose not to have operations, and they compared with the general population. And again, in the last 6 months, they choose not to go to intensive care. And that's they will have the best health insurance. You can guarantee that in the US as well. They choose not to have intervention. Thank you very much.
Just stick your hand up and a mic will come to you. Okay, there's one top left. Not sure who's got the roving mic. Just,
Hi, I'm Lindsay Fielden, Forth Valley. I'm a geriatrician, so thank you very much for your talk. I was going to ask you firstly, you touched on it with your case. How many of a lot of what you presented was, quantitative research? Do you know the numbers of patients that, have quite a complex admission and look back and say, I would do that again versus I would not go through that again? And also just a point about how we communicate with our patients. I think we can influence that heavily as clinicians in terms of, paternalism. Sounds like you had a very balanced conversation with that patient. However, some of the time that can be I wouldn't recommend this for you, rather than having sort of honest conversations about what the risks are to the patient.
Yep, I think there were again some quantitative data. This was done specifically around COPD and intensive care admission. There's an international feeling where we are nihilistic in the UK compared to other countries. So it's very specifically binary question, would you do that again? And the majority of people who survived after 12 months would do it again. A very selected population because they managed to get 12 months out. There's a big qualitative work program going on in Edinburgh about people's experiences. That older population are less well represented because they are not well enough or alive actually to have those conversations. They have to happen down the line from intensive care. So from that point of view, that's more challenging. From your point about paternalism, absolutely, the traditional model absolutely has been within critical care and sort of still is, in many ways, as gatekeepers to these precious beds, is around that isn't going to do, that's not going to do. And part of that does come from not so much, I wouldn't say it's balancing the other medical ethic of distributive justice. If we admit that person, the young person with pneumonia might well die, who has a much higher chance of getting through. So I think we are all absolutely obliged. I think we have to, it's going to happen whether or not we want it to move to a shared decision-making model. But I think doing that sensitively and not dressing things up as, well, there might be a bit of a problem here. These are real challenges people go through. I have to say, I think geriatricians are the one specialty where those conversations are done well. And we know that from the number of times we have contact with our geriatric colleagues in terms of patients who they think are suitable for critical care. It happens less well in non-medical specialties, I would say, where there's a default reflex that we will get involved. But yeah, I think that balanced approach is absolutely the future, I think.
There's another question right up at the back.
Kathleen Caper, Hospice UK. You spoke about having a conversation about with the patient about making a choice between comfort care and ICU intervention, surgical intervention. Can you say a little bit about the role of palliative care in an ICU, whether it is something that it's a different specialty so it's handed over, or whether it works, I suppose, whether it dovetails in?
Yeah, in the UK there isn't actually a huge joined up approach between palliative care and intensive care. You do find that often in cancer specialist ICUs, where the palliative care team are very heavily involved. There aren't that many around in the UK. America's a very different model. American, I think because of the nature of what's happened there, they have a lot of people, difficult conversations, and palliative care in many units is integrated in. And it appears to be honest, when you read the literature, that's around having the conversations. I think that's what we do, and death and dying coming off life support, which is often, a lot of our deaths are coming off on life support, and a withdrawal of aggressive treatment and move to comfort care. I think that's something we feel we do pretty well, especially when we offer bereavement visits in Edinburgh to families who come back, and that's one thing they do say is that was a peaceful, they were given privacy, and they felt that was moments they could cherish at least. What we don't do well about at all, and I think this is the big gap, is what happens after that. And I think at least in hospices, through hospices, bereavement is a real issue and aware. It's not just the patient, it's the family. It's all about the family until the patient dies for us. And then we actually have no rights of medical access to GPs for relatives. We don't know who their GP is, even if we were worried, particularly in some traumatic deaths, to flag that up. So I think there is definitely a role. I think so far there are so few palliative care doctors working in the acute sector in Scotland that I'm not sure there's necessarily a huge rush to add to their workloads as well. I personally, having worked quite heavily with palliative care doctors as a respiratory specialist, I think it could only be a good thing. I'm not sure all of my intensive care colleagues feel the same.
Time for one more.
One just there.
Thank you very much. I'm Maura O'Riordan. I'm a palliative care specialist in Glasgow. I was just about data and evidence and sharing that with patients. I mean, obviously it's very important, but it's also what the patient interprets from giving them figures about survival and so on can be quite different to what you want to get across to them. So a 5 to 10% survival, to you, you're probably thinking, that's very poor. The patient's thinking, well, I might be one of that 5 or 10%. I just wondered really how helpful you find that at the end of the day. And the other thing was just to ask what happened to that patient.
I guess I left you hanging. I was meant to say about that. I'll maybe start with the last bit. So that patient I looked up actually, because obviously a classic, they leave ICU, I never see them again. I actually was really interested there and looked up, and he actually spent a month and a half in a surgical ward, eventually moved out to rehab, and then died in rehab about 2.5 months later. So I'm not sure if actually maybe if that was the time he needed to tidy stuff up, speak to family, maybe that was valuable time for him, I don't know. But that's what happened. That is always our worry. That's what happens. People can't get home. They end up in these situations they would never have wanted to be in. Around facts and figures, I absolutely agree. I think one of this is about how you present it, because often I've had the response, that daughter's response, well, if it's 1 in a million chance and you can't say for certain, he should have that 1 in a million chance. And I think one of the issues there is around it's not about death and alive and independent. There's actually this other bit in the middle of pain and suffering as well. The bit, though, I think is actually slightly different is people come in thinking there's 100% survival, genuinely. And so actually even being able to say the patients who come in with after out-of-hospital cardiac arrest is one of our biggest group now, and they have pretty terrible outcomes. And actually That's a family who might have been doing CPR at home, waiting for the ambulance, thought they'd lost them. We managed to get them back, and they finally see them in ICU looking asleep, hooked up to life support machines. And at that point where they think, oh, thank God. And that's when actually, if it's not the first conversation, we usually check. It might be this, we have time, so it could be the second conversation the next day. We have to get across that actually, for every 10 people who come in, 7 or 8 will not leave the ICU, and 1 or 2 additional will end up with severe brain damage. So, and it's when they hear that, there is this sudden total change of what this means. So I think as a realizing what this means generally, rather than necessarily about the fine decision making, is a very helpful tool if people want it. Some people just would much rather we speak in vaguer terms, and that's how they process the information as well.
So I think we'll probably have to leave it there. I think you're around for the bit longer?
I'll be around at lunchtime.
So if you've got more questions for Naz, catch him at lunchtime. But perhaps we could thank Naz again.